That's good to hear.
So,
Yes, please.
we have talked about traumatic fever, and
Hmm.
it's a cause list like as the disease or the injury, and the scar is the rheumatic heart disease. Could you please
Yeah.
tell me the major criteria for diagnosing a rheumatic fever?
Yeah, major criteria is going to be the Jones criteria. So you're going to have like joint arthralgia. You're going
No,
to
no, no, no.
have
Joint arthritis. Arthralgia
joint
is a minor
arthritis.
criteria. Arthritis is the
Minor
major
criteria.
one. Good.
Gotcha, gotcha. Sorry. So joint just complications, joint arthritis. You're going to have cardio cardiomyopathies just because of the O.
Carditis.
For
I would be having
carditis,
carditis.
carditis.
You have to know that like rheumatic fever is an acute disease. So we don't have enough time to have cardiomyopathy or even a valve disease. So it's just carditis. It's inflammation of the heart that would be presented by PR interval prolongation. Maybe
Gotcha. Okay, so
some
just like
pain.
a more brief. Okay, okay.
Mhm. Mhm.
Okay, so Geo, and you have the nodules,
Mhm.
the subendothelial nodules, I think that's what it is.
Subcutaneous
Uh
nodules. Yes.
Subcutaneous, not Geo and E, this is erythema migricans
Erythema
or
marginatum.
marginatus.
Yes. Yes.
Marginatus. Yeah. Then we have yes, S was the what was S? I don't remember the S.
Sydenham's
What it
chorea.
didn't yeah, okay, the Korea.
So learning is a very complicated process, and a very important like uh, factor that would be helping is repetition. So after you get this decision, you have to read the PDF or read your textbook or anything. It's some sort of repetition that would be very helpful. I
Yeah,
don't believe
otherwise it's not gonna stick. Yeah.
yeah, yeah. I don't believe a single time of decision right saying the info for one or two times it would be enough. You have to do multiple revisions. That cardiology is very hard. We have to know it. Cardiology is very hard, so you have to be doing more revisions than other branches.
Gotcha.
Okay, we have stopped that aortic stenosis and the treatment. We have two options. If it's very
Yeah.
severe valve problem, we have valve replacement by open procedure. So if I'm replacing the valve, I am removing the old one and I'm putting a new one and I'm doing stitches. So it have to be an open procedure. I have to be doing a sternotomy and seeing all the heart. So I could put my hand and do stitches of the new valve. So it has to be open. So for valve replacement equal open procedure. But if I'm just needing some sort of dilatation, then I could be introducing a catheter through femoral vein and just, inflating this balloon. It would be causing dilatation of the valve, but it's not very helpful in many cases. A side effect of it could be regurg. So the patient has stenosis, but after dilatation, I could be inducing regurg. So
Regurgitation.
yeah,
Gotcha. You can have another problem.
yeah. It's a simple procedure, but it's not. Yeah, it has many complications. But I do it in patients who can tolerate open heart surgery because it's a major surgery.
Mhm.
Okay, and for sure I will be doing medications for heart failure and Okay,
Monobatch.
then we are going to know a little about aortic regurgitation or aortic
Yeah.
regurg. So it could be a primary valvular disease, the valve itself, but bicuspid valve. It's like something congenital. It's
You're born
two
with Turner
cuspis rather
syndrome
than
can be
three,
seen
so
with
it's
the
it's little weak valve.
yeah. Hmm.
Inflammatory scarring, endocarditis, and you have to know that endocarditis cause regurg, but no stenosis. Why? Endocarditis equal regurg, but no stenosis. Why?
So just due to like the inflammation, so you're pulling the papillary muscles like apart, causing the regurgitation, rather than like actually affecting the valves directly.
It's rational, but medicine is not dependent or not based on simple thinking by any means. You have to know it.
Sure. Yeah.
Uh,
Gotcha.
yeah. Endocarditis is an infection, bacterial infection over the heart valves. Because valves are fibrous tissue, it has no vessels, it's avascular. So an infection could easily bacteria could be easily growing on these valves. And
Okay, yeah, makes sense.
yeah, so we'll be having like vegetation or little masses of bacteria over the valves. That's endocarditis. This bacteria itself and the neutrophils and some immune response around it are producing proteolytic enzymes and the bacteria itself. So if they are gonna affect the valves, they are gonna like making a lysis or dissolve this valve. So this valve, if it's affected by endocarditis, it would be having like pores. So the valve
Hmm.
would be having like pores. That's the definition of regurg. So bacterial endocarditis is causing just a regurg, no stenosis, just dissolving some pores of the valve and making it like porotic or have pores. So it's a sort of regurgitation. Systemic
Gotcha.
lupus,
Okay.
calcification. Marfan, you know Marfan?
Yes, yes. Autosomal dominant issue with collagen,
Yeah,
really tall, the
really
concave
tall, and
chest.
his collagen is hyper elastic.
Hmm.
So because it's hyper elastic, this valve is not it's very elastic. So it when the blood pushes it back, it gets this way. This valve is moving down, so it goes as regurg. It's like this, and it permit blood to be down into the ventricle. It's very elastic valves and very elastic. Every collagen in this patient, in this Marfan patient, is hyper elastic. His could be like doing hyper elastic movements with his joints.
Hmm.
Yeah, that's Marfan syndrome. So it's a source of regurgitation, not a stenosis. SLE, ankylosing spondylitis, rheumatoid arthritis is source of inflammation, autoimmune inflammation could be causing regurg and also stenosis, by the way. And most common in developing countries like in Egypt, it's rheumatic heart disease for sure. So,
Gotcha. Rheumatic heart.
rheumatic heart disease causes mitral valve problems and aortic valve
And
problems.
aortic.
Which
Yeah.
is more common?
Mitral.
Yes, mitral is more common, and it's more common to be mitral stenosis.
Hmm.
I haven't inserted my graphic tablet. It's more common to be a mitral stenosis than to be an a mitral regurg, by the
Aortic
way.
regurgitation. Okay, so stenosis is just more common in terms of
Yeah,
in
in
general,
terms of
whether it's
mitral.
mitral.
Yes.
Okay.
يا مكاري ناولني الوصل يا مكاري. So in terms of mitral, stenosis is much more common than the aortic one. حد يناولنا الوصل يا ولاد. And for aortic regurg is much more common than aortic stenosis. So for aortic regurg is much more common than the aortic stenosis. That's for the aorta.
Okay. So yeah, that's just the opposite in that case. Mitral stenosis more common than mitral regurg. Aortic regurg is more common than aortic stenosis. Okay.
So if I have a mitral, sorry, I have been disturbed. So if I have a mitral problem, it's more common to be a mitral stenosis than a mitral regurg. I got my graphic tablet. It's very helpful.
Yeah.
And
Okay.
if it's aortic, it's more common to be aortic regurg than aortic stenosis. And it's
Yeah.
far more common to be mitral than aortic. So mitral is much more common than aortic. Got me?
Yeah. Mitral.
I believe it's high yield information, although most of it is not written in your lecture. But I have solved many questions around these topics in the past, and I believe I know it very well.
Yeah, yeah, I agree. I mean, it's common that they'll ask me like, oh, like rheumatic heart disease is associated with like what kind of murmur, like what kind of um
Mhm.
valvular issue. So
So, aortic regurgitation could be acute. And by the way, it's not the case in rheumatic fever. Rheumatic fever, it's almost always chronic. It could be
this is a
acute.
long
Yeah,
time. Hmm.
yeah. It could be acute in endocarditis, by the way. Take days, endocarditis. That's acute
Gotcha.
aortic regurg. Yeah. So if it's acute, maybe endocarditis, maybe acute rupture, of a valve leaflet or something. And for sure it's acute, then the left atrium has no time to be enlarged. You know, enlargement or dilatation needs time.
Yeah.
So left atrium would be normal size. And also left ventricle. Dilatation takes time. Oh, and it's years, even not months. Left ventricular pressure, because it's still small, would be high. This regurg would be increasing pressure of the left ventricle. Left atrium would also be having high pressure because it's small and tight and having a lot of blood. Presentation collapsing, it's acute presentation. For chronic, it's chronic disease like rheumatic fever. It's dilated. So we have time for dilatation of the left.
Dilatation, yeah.
Yeah. And we have normal pressure because it's dilated chamber. So all this blood wouldn't be causing a lot of pressure. Also, he's a walking around patient. He may be very normal, but have some sort of failure, whether it's dizziness or the symptoms of failure we have talked about many times. So chronic aortic regurgitation has another name, regurgitation equal insufficiency, by the way. So it's insufficient. It's sufficient. It's not enough. It's not doing.
Yeah, not closing properly.
Not doing his work well. His work is to close and prevent blood flow back. So it's insufficient means it's doing regurg. So
gotcha.
It's normal systole, very normal systole. But when we get into diastole, aorta should be closing right here. Should be closing its valves. In this case, it's not closing very well. So this is the normal one. In this case, I will be having flow back during diastole, and it's a diastolic murmur. And it also would be increasing pressure in the left ventricle during diastole. That's the normal pressure. It should be very low during diastole, but in aortic regurg, it would be very high.
Increased pressure because of the fact that you have backflow.
Yes.
Okay.
So aortic regurg could be acute, like incompetence. It would be causing pulmonary edema, and it would be emergency. You have be doing valve replacement emergently. Chronic, long-standing dilatation, dyspnea or stopnea or paroxysmal, but yeah, it could be a walking patient. It could be, having a normal life, not collapsing to the floor, exercise intolerance. Yeah. And frequent premature contractions. Can you tell me why? So in chronic cases, we would be having frequent premature contractions like foci or arrhythmias, tachyarrhythmias, by the way.
Yeah, it's the similar concept to what we talked about with the arrhythmias, begin with kind of why they're happening or why they can occur due to dilatation, causing the more travel time. So you have the increase in kind of like nodal firing. So you just have like constant kind of contraction. Just because like you're messing up with like the normal electrical rhythm of everything, just because the heart is expanding itself. So the not entirely sure how to explain it. If I'm
great. You have a very good point that ventricular or atrial dilatation equal arrhythmia. That's great. That's very right. Equal arrhythmia. But the mechanism, we need to talk about the mechanism. This dilatation means, dilating these fibers means it have gone into a great pressure that has caused some sort of ischemias and fibrosis. And this fibrosis and ischemias have different conduction velocity than the heart, which would be making reentrant circuit. Reentrant circuit we have talked about many times?
Yeah.
That's the mechanism, by the way, because we will be having some tissues right here that is conducting electricity in a normal velocity, and some tissues on the other side of the circle conducting it in a lower velocity. So electricity would be moving in circles before getting down, what we talked about.
Yeah.
That's the mechanism why dilatation causes arrhythmia. It's premature ventricular contractions. It's arrhythmia, contraction in the ventricle, which is a sort of arrhythmia. Okay. So we have regurgitation. And the diastolic blood pressure is falling. Because the diastolic one is dependent on the aorta, but we are getting blood is getting back during diastole. So the aortic pressure is low.
Yeah.
That would be causing myocardial ischemia. It's very important, high yield. Why? Because the coronaries are filling during diastole.
But hold on, sorry. Can you hold on? You have regurgitant volume. So yeah, you have aortic. The aortic valve is not working properly. So um, you're having a backflow into the ventricle, into the left ventricle, which is causing. Oh, okay. Sorry. I think I confused diastolic blood pressure with end diastolic volume. Okay. Yeah, because you would have an increase in end diastolic volume because it's regurging back into it.
Yes,
Uh,
exactly. Yes, we
but
have.
okay,
Yes. But we're
gotcha.
having
Okay,
decreased diastolic pressure, but increase in diastolic volume. Yes, you got it right. So
okay.
the first branch of the aorta is the coronaries, right?
Hmm.
So we have the coronaries that's giving blood to the heart. Do you think the
Yeah,
heart muscle is taking its blood supply during systole or diastole from the coronaries?
I guess during diastole because that's when it's like filling up, like it's more time to actually.
Yeah, it's more time and it's not contracting muscle. Contracting muscle are pressing on these coronary branches and not leaving it. It's pressing on the branches, so it's closing it during systole. Contraction is
Mhm.
pressing on the coronaries, but diastole we are relaxed and we are getting blood. So diastole is the phase that the heart takes its energy. But in
Gotcha.
this patient of aortic regurg, diastolic blood pressure is very low.
Okay,
So,
okay, yeah. So you're
so this
decreasing
patient would
diastolic
be
blood
greatly
pressure,
suffering from
decrease.
angina. You
Gotcha.
know,
Yeah.
you would be finding angina in almost in aortic stenosis. You would be finding angina, but it's pretty much common right here. The patient would be having anginal pain, pretty much common and pretty much important. And for sure, ventricular dilatation and eccentric hypertrophy. The same we have talked about
Yeah.
very much.
Of
Yeah.
all the modifications that happen. Yeah.
Yes. In aortic insufficiency, we have something called widened pulse pressure. Do you know about it?
Widened pulse pressure. We covered a similar topic to this yesterday. The pulse pressure is the difference
Yes.
between we said this was a diastolic and systolic, if
Yes,
I'm not
exactly.
mistaken. So, which because you have a change in your diastolic pressure, um, that's why you would have a change in pulse pressure in general, because
Yeah.
like the two numbers are changing. Okay, yeah.
So yeah, in this patient, when I'm feeling his pulse, I'm feeling it pumping, pushing my hands. It's very hard. It's very pushing because it's widened. Pulse pressure is what I feel. I'm not feeling a pressure. I'm feeling the difference. So in every beat, systolic is pushing my hand when I'm feeling the patient pulse. It would be low diastolic pressure. It would be a hyperdynamic left ventricle trying to compensate. And this hyperdynamic makes, very, very interesting science. I have seen patients with aortic regurg doing like this.
Hmm.
Involuntary. It's, this big amount of blood moving through his aorta, up and down, up in systole, and then down in diastole because of regurg. It's like, it's about 5 liters per minute. It's making him vibrating. It's called
Yeah, just
Demosay sign.
rocking.
It's pretty much
Demons. Yeah.
important. It's head bobbing
Gotcha.
or head nodding. It's like this. Also, Corrigan sign. Corrigan sign is what we feel. It's called water hammer burst. It's like a hammer pressing but it's actually a water or blood pushing my hand when I'm feeling a pulse. Something also called Quincke's pulsation. Normally I have arterioles in my nail beds. I have arterioles in my nail beds, but it makes
Yeah.
very little pulsation that when I put my hand, I couldn't feel it. So I have a pulse in my nail bed, but it's very little. I couldn't feel it. But
Yeah,
in
you can't feel it.
aortic insufficiency or aortic regurg, I have big pulse volume. So I could feel the pulsation in my nail bed. That's Quincke's pulsation or arterial pulsation in nail bed. You know, you don't have to care a lot about the names. You have to know the sign. I know the names are
Gotcha. Yeah,
very
what
hard
you
to
see.
know. So you have
So
to know
so
that head
because
bobbing
we
is
have
associated with aortic. Sorry.
sorry to interrupt, but because we have a regurgitation, the when you are undergoing systole, right, the heart has to push even greater volume than it would normally because of that regurgitation,
Exactly.
and that volume, that increase in volume, is what's causing these pulses that used to be diminished to be able to be felt now because you just have an increase in volume that's going through. Is that correct?
Yeah, because we have increase in volume. That's a point. And the other point is that diastolic is very low. So what I'm feeling is the difference.
Hmm.
What I'm feeling is the
Gotcha.
amount that's being, because I have very low amount of blood here, and it's the left ventricle is pushing a lot. It's pushing a lot. It's pushing the amount of blood that's coming from the atrium, which is like normally it's 70 milliliters, and it's
Hmm.
also pushing an additional amount of blood
Whatever
that
came
that
back.
comes through regurg, like maybe 30 or 50 milliliters. So it's pushing like 120, and it normally push 70. So yes, exactly what you say. Yes,
Okay, okay. Yeah, that makes sense. Thank you.
welcome. There sign or there murmur. It's diastolic murmur produced by pressure on femoral artery. When I have my stethoscope and put it on my femoral artery, normally on pressing the femoral artery, I could be feeling a systolic murmur. But because I have a back flow of blood, so it's the femoral artery, in diastole, blood flows back through the femoral artery, then get here to the aorta and flows back through regurgitation. So I'll be feeling diastolic murmur, and it happens exclusively on aortic insufficiency. Blood is flowing back just because the aorta is making it flow back. And why specifically femoral artery? Because it's very wide artery. So
Gotcha. Yeah.
I'll be hearing something. I will be having diminished A2. Why do you think we have diminished A2?
A2. Okay, so that's just the diminished A2. Oh, because it's not closing properly. A2 is basically the sound of the aortic valve closing.
Yes,
So when it's regurgitated or insufficient, it's not going to be able to close properly or as loud or so that's why you have a diminished A2 sound.
great. And the name of the murmur, you should know it's diastolic, and it's called decrescendo. Decrescendo is like decreasing murmur. So when systole ends and diastole begins, there would be very high pressure in the aorta. So at first it would be very high flow of regurg. Then it would be decreasing a
Gotcha,
little.
gotcha. So
Yeah,
loud
so it's
sound.
decrescendo.
Yeah,
Yeah,
as the
it's
pressure
louder.
equal, it's
Yeah, louder at
oh, okay,
first,
okay.
and then
Sorry, that
it
makes
would be
sense.
decreasing. Yeah, great.
Hmm.
Austin Flint murmur, I believe it's the most complicated murmur you would be getting in cardiology. Do you know about it? Austin Flint murmur?
No.
Okay, so let's try to understand Austin Flint murmur. And you have to know it just for exam. It's pretty much hard to be able to listen to all of this during a couple of milliseconds.
Yeah.
Great. So this picture is great, by the way. In the anatomy, the aortic valve is pretty much close to the pulmonary valve. So, and aortic regurgitation occur during diastole. So this one in green is occurring
Hmm.
during diastole.
Yeah, there's the feeling.
Also, during diastole, the atrium is pushing blood to the ventricle, or there is blood flow from the atrium to the ventricle, also during diastole. So this
Yeah.
one and this one occur at the same time. Okay?
Okay.
And the aortic valve and mitral valve is very close to each other. And this backflow of blood from the aorta to the ventricle would be um, like, pushing this valve leaflet.
Yeah. We're
Imagine
just
it.
pushing it open. Yeah.
Yeah. And this pushing would be like making it like more stenotic or more narrower, you know it?
Okay, yeah. So basically the regurgitated or the insufficient aortic valve is compressing the mitral valve just
Yeah.
due to its proximity when it opens
Yeah.
again.
So you would be
Okay.
hearing the sound of mitral stenosis, and the mitral is very normal, by the way.
Yeah, even though
That's
it's normal.
Austin Flint murmur. It's a diastolic rumbling murmur. It's mitral stenosis murmur. Mitral
Okay, so you
stenosis is called,
basically, yeah, you hear mitral stenosis murmur and aortic regurgitation at the same time, or not at the same time, but like you hear them both, or just one.
for me and you, we are not hearing anything. It's very hard to hear any of them. But yeah,
Gotcha. Yeah.
but yeah,
Okay.
we should be hearing mitral stenosis and the aortic regurgitation at the same time. I don't know how. Yeah, you have to know it. Yeah, I've been trying very very hard to be able to listen and know like click and even diastolic murmur. By the way, by definition, systolic murmur is very loud, so you could be hearing systolic ones if you have good training on it. But diastolic ones are actually very hard to listen to because it's very like it's very low pitched and very low, and it's not loud sounds. So
Yeah,
I
yeah,
believe we couldn't hear any of them, but we have to know it for the exams.
yeah. How they describe it, yeah.
Yeah. So you would be hearing the sound of mitral stenosis in the same time, and with the sound of aortic regurg. Aortic regurg is a decrescendo diastolic murmur, and mitral stenosis is a mid diastolic rumbling murmur. We will be getting into its details within a couple of minutes, I believe.
Okay.
So aortic regurg takes all the diastole. So I will be having this sound all the diastole. I will be having backflow of fluid, but it would be very loud in the early diastole, and it would be decreasing. That's decrescendo. We have another sound called crescendo decrescendo. You remember it?
Yeah, crescendo crescendo, yeah. It's
What's
the
it, what's the murmur? What's the stenosis? What's
yeah, what the type of issue is it?
yeah.
It's the one where you have crescendo decrescendo. So it starts off loud and then it diminishes. So is it the like is it not aortic stenosis or just stenosis because you start off with the opening snap, so it's
No, no,
very
no, no, no,
loud at the
no.
beginning?
It's actually aortic stenosis. Aortic stenosis murmur is called crescendo. Crescendo means increasing. Decrescendo. That's because the flow is first during contraction. It's increasing all over the systole because the flow is the maximum at the middle of the systole. The first phase is called isovolumetric contraction phase, and the last one we have little blood left.
Yeah,
The middle
relaxation. Yeah,
one is,
yeah.
is, is the increase. So it's crescendo, increasing, and decrescendo. This is the aortic stenosis murmur, and this is systolic murmur. In this part,
Is that not what I said?
it's aortic stenosis, and this is systolic murmur, systolic.
Okay. Yeah.
This one, aortic regurg, is a diastolic murmur. And
Yeah. Oh
the
yeah.
pressure gradient between the aorta and left ventricle is greatest at the first of diastole. You, good? Are we good?
Yeah.
So blood would be
I will
moving
say that I
very
think this
fast.
is the first time I actually understand the mechanism behind the sounds. So thank you.
You're welcome. Thank you. So an aortic regurg, systole would be very fine. So S1 and S2 would be very fine. After S2, in the diastole, I would be having regurg. I would be having regurg fluid from the aorta to the left ventricle. So I would be having a sound very loud in the early diastole because there is a great pressure difference between aorta and left ventricle. So it would be
Hmm.
very high flow, but it would be decreasing because by
Yeah.
time the flow would be, there wouldn't
Equal.
be a lot of difference. So it's
Hmm.
called decrescendo. That is decrescendo. It's a Latin word means decreasing. That's the aortic regurg one. And this is the
Yeah.
aortic stenosis one. I believe they are a little hard, so it's fine to be asking a little hundreds of times. I don't have a problem. So if you want me to repeat it, it's very fine, by the way.
Gosh, I think for right now I understand why they sound like that. So I'm okay for right now.
Great. It's very fine to be forgetting it. So I recommend that you read the lecture after we end it, and then do spaced learning. So you read it today, read it 1 week later, and then 1 month later, you have to be doing spaced learning and increase the periods between repetitions. That's very helpful, by the way.
Okay. Gotcha.
Aortic insufficiency or aortic regurg diagnosis. The patient could be having bicuspid valve, infective endocarditis, Marfan, and for sure rheumatic fever. But in
Hmm.
your country, rheumatic fever is not very familiar, so is mentioning the
Prominent.
common ones
Yeah.
in your countries. You have to be thinking of it if you have someone from immigrants, from Egypt or something.
Hmm. Hmm.
Physical exams, yeah, an EKG you would be having. It's aortic regurg. So first we would be having left ventricular dilatation. And then we would be having backflow in the left atrium. So we would be having left atrial dilatation. So in ECG, I would be having both dilatation, left ventricle and left atrium. And we would be having some sort of hypertrophy beside dilatation at first, by the way. So it would be
Okay.
little high.
Oh yeah. Gotcha.
And for chest X-ray, the left ventricle would be enlarged, so there would be dilatation of the heart. And for echo, you would be seeing the regurgitation and the backflow of blood. You would be seeing everything. Echo is the boss in all valve
Hmm.
disease. Echo is the boss because I'm
You
seeing
can
it.
see everything. Yeah.
And
Gotcha.
who is the boss in coronary artery disease? Who is the gold standard investigation in coronary artery disease?
Coronary angiograph.
Yes, great. Very, very high yield questions, by the way.
Gotcha.
Great. Therapy, it's aortic regurgitation. So we have dilatation in the ventricle and the atrium. So for sure we'd be having arrhythmias, the mechanism we have talked
Hmm.
about. So we'd be
Yeah.
giving anti-arrhythmias. We'd be giving diuretic to control failure. Diuretic nitrate vasodilators, they are reversing the compensation mechanisms to control failure. And for sure, if it's very severe, we'd be doing valve replacement or valve repair, and replacement through open procedure, and repair is through the
Yeah. What we
stents.
said before. Yeah.
Yes. Uh, yes. Great. Then we are talking about mitral regurgitation. So, what is the most common valve to be affected in rheumatic heart disease?
Mitral.
And what is the most common problem in the mitral to happen? Mitral regurg or stenosis?
Most common for stenosis. Mitral stenosis
Yes.
versus is greater than mitral regurg.
Great. That's right. So normally its blood pressure in the aorta is 120 to over 80, or it's fine to be 110 over 75. And blood pressure in the left ventricle uh, is around 100 to 20 or 15 in the left ventricle.
Hmm.
The problem right here is blood would be moving back from the left ventricle during systole, during the push of the ventricle, blood would be moving to the aorta and also to the left atrium. And this blood, so left atrium normally would be having 70 milliliters, but in this case, it would be having 70 milliliters and like extra 30 from the regurg and mitral regurg. So it would be having a volume overload. And in the next cycle, it would be pushing those 100 milliliters into the left ventricle. Left ventricle would be trying to push all of them in this way in the aorta, but some of them would get back to the mitral and we would be having around 100 rather than 70, you know? So normally we have 70.
Yeah,
So
yeah.
we have volume overload every cycle. And by time left atrium would be dilated and left ventricle would be dilated, and we would be having back pressure over the lungs.
Yeah.
Okay. And it's telling you why mitral valve is the most common valve to be affected, because it has increased pressure gradient all over his valves. Let me try to make it more clear. You know, what's pushing the valve is a force from this side and
Hmm.
another one from this side. In the
Yeah,
aorta,
yeah, yeah.
the difference is very little. It's just around 70 or 60 in diastole. So there's not very much stress over the aorta, but there is very much stress over the mitral, because the pressure right here is very low in the left atrium. It's minimal. So he has a lot of pressure in every cardiac cycles. Blood is pushing over it very hard. That's why, you know, it's most one to be suffering from wear and tear in our body.
Yeah, I gotcha. That makes sense. Gotcha. Gotcha.
Great. We have primary mitral problems like structural defect of the valve,
Hmm.
and we have secondary ones like the one we talked about, which is called left ventricular dilatation. You know, the cusps are very far from each other because the left ventricle
Yeah.
has dilated. It's as an example of secondary cause of mitral regurgitation. Let's talk about some examples. You know, I believe this slide will be taking us very much. Do you have time today for another meeting or?
No, I have class again. I have to start heading to my lecture right now in like 2 minutes.
So it's fine to end and
Yeah, we
start the
can
slide next
end
time.